Today we are conducting a case conference to clarify which role we will each take in supporting Nadia, a 12-year-old Sudanese refugee who recently arrived in Australia. The aim of this meeting is to clarify our roles and put together an intervention plan for Nadia. Today we have Rebecca Best, clinical psychologist, Samuel Bryce, clinical neuropsychologist, and myself, Stephanie Zimmerman, the school psychologist from Nadia's new school, specialising in educational and developmental psychology. When Nadia was 6, she and her family were forced to flee their village, which was attacked by rebels. During their flight, Nadia experienced significant trauma and also sustained a head wound. Eventually, they reached a Kenyan refugee camp, where they remained for 6 years. Earlier this year, the family was granted refugee status and relocated to Australia. Nadia appears to have problems focusing. She often has violent outbursts and sometimes seems disoriented. Her teacher is concerned she is not connecting well with her peers and is being teased. Additionally, her teacher is finding her inattention and outbursts disrupt the class. In the literature, it is understood that there are 3 stages refugees go through: pre-flight, flight, and resettlement. Each come with their own challenges. During the pre-flight period, children are often exposed to social upheaval, disruption to education and development, and ongoing threats to safety. During flight, where refugees are displaced from their homes, there is a high risk of additional stresses, which may include separation from family members and lack of food and water. Further trauma often occurs after arriving into the relative safety of refugee camps. Finally, the resettlement period brings with it its own challenges, particularly navigating a foreign cultural system and integration into their new surroundings. The process of adapting to a new culture, called acculturation. For child refugees, these challenging experiences often occur during important developmental periods, increasing the risk of cognitive impairment, delays in development, and behaviour and mental health issues. On a biological level, these issues can be explained by trauma experienced interfering with normal neurological development, resulting in alteration of brain structure and function. This can result in altered behaviours such as decreased executive functioning and reduced prosocial behaviour. See Music 2012 and 2014. As a school psychologist, my role is to aid students in overcoming barriers to learning and improving their academic performance. See the Australian Psychological Society, 2016. Review of the relevant literature highlights a range of protective and risk factors for both mental health and education in child refugees. As demonstrated by this table I created from 2 reviews, Nadia's experiences present multiple risk factors for both mental health and learning. As a school psychologist, I am in a unique position to intervene to reduce these risk factors and increase protective factors. Qualitative Australian research with young refugees has demonstrated that they struggle with navigating institutionalisation of learning in Australia. See Gale, Bolton and Martin, 2010. To assist with this, I intend to meet with Nadia regularly to touch base and address any concerns she is having with school and culture. There is a clear implication that risk factors can be reduced and protective factors enhanced through appropriate approaches of teachers. Therefore, I will also run a short workshop for our teachers regarding working with refugee children, highlighting the importance of positive expectations, cultural appropriate approaches, and the impact of trauma. I will also suggest a review of anti-discrimination policy within the school, as Nadia's teacher has suggested that this is an issue. This must be immediately addressed, as racism is a risk factor for both mental health and learning in refugees. My primary focus will be running a parenting intervention. One big reason that parenting intervention could be of value is acculturation rates in children and parents occur at different rates. Children's regular attendance in school results in increased acculturation rates, see Huang 2006. This can cause various strains on the children, including strained relations between parents and children. This is called acculturative family distancing and actively undermines family cohesion. Family cohesion is protective for both mental health and education. Parenting intervention, therefore, has the capacity to simultaneously enhance both protective factors on both fronts. Prior research has shown that parenting interventions with African migrant and refugee parents in Australia has been successful in increasing parental empathy, promoting more appropriate expectations of children, altering attitudes towards corporal punishment, and reducing role reversal between parent and child. See Renzo Ho, 2011. Though all these interventions would be really beneficial for Nadia, given the serious nature of her traumas, she would also benefit from individual psychotherapy. On that note, I will hand over to Rebecca Best.
Thanks, Stephanie. From a clinical psychology perspective, refugees often experience multiple traumas and can include any of the following: violence, death, starvation, forced displacement, loss, threatened or actual injury to the individual or a family member. The type of exposure and severity experienced by Nadia is important to determine the level of psychological distress and risk for mental illness. Mental illnesses commonly associated with trauma include post-traumatic stress disorder, depression, anxiety, grief and loss. However, different risk factors appear to relate to certain mental illnesses. Exposure to personal and/or family trauma such as violence, torture, displacement, injury and starvation places Nadia at high risk for developing PTSD. Research indicates that for each additional traumatic event, the greater the severity. The prevalence of PTSD in refugees is extensive, and symptoms may include emotional detachment, nightmares, hallucinations, increased arousal, violent outbursts, and re-experiencing the event, and trust issues. The manifestation of depression appears to be linked to the amount of social support Nadia has, recent life difficulties, socio-economic status, and stress experienced in the new host country. The post-migration environment is thought to influence the prevalence of depression and possible comorbid PTSD and depression. Anxiety has been less frequently investigated. However, in the studies that have been performed, comorbid with PTSD was common. For example, Hubert, Realmuto, Northwood and Maston reported 20% of Cambodian refugee adolescents exposed to war trauma had PTSD, of which 57% also reported generalised anxiety disorder with or without major depression. Nadia may also have been subject to multiple losses, including loss of family contact, death of friends and family, homeland, status and culture. Symptoms of loss include sadness and a low mood that may lead to isolating oneself. Therefore, it is important to acknowledge the grieving and adjustment process, but also ensuring Nadia's grieving is within normal limits. Other problems that are commonly reported in refugee children and adolescents include social withdrawal, behaviour problems, difficulties in peer relationships, conduct disorder, attention problems, restlessness, and generalised. Key factors in Nadia's treatment process include the therapeutic alliance, assessment, therapy, and evaluation. Each step plays an important role for the success of treatment and will be discussed. The therapeutic alliance is one of the most important factors in the therapy process and has the ability to impact the effectiveness of therapy. Key factors in building a therapeutic alliance with Nadia include explaining the therapy process, discussing confidentiality, establishing a safe environment, and building trust. Only after Nadia feels she has a level of predictability, safety, and trust will she be ready to begin therapy. Assessment provides the ability to determine Nadia's current mental health and any underlying mental illness. The process is ongoing and will include the use of validated self-report measurements, visual observation scales, and feedback from Nadia. It is imperative to use precaution when interpreting Nadia's results, as these are generally standardised to first world populations. Comorbid conditions must also be taken into consideration, as these have a greater level of disability if they are present. The form of therapy used in Nadia's case will be family therapy and cognitive behaviour therapy, which incorporates an aspect of exposure therapy. Research suggests that families can act as a defence against stress and play an important role in emotion and identity attachment. Family cohesion before and after migration appears to protect children's emotional well-being after traumatic exposure. Furthermore, psychological distress and stress reactions are increased when the mother of refugee children has poor mental health. Therefore, engaging Nadia's family and determining Nadia's mother's mental health is imperative for the best possible outcome. Large amounts of research have been performed on the efficacy of CBT It appears that CBT is effective in treating a wide range of issues, including depression, anxiety, PTSD, obsessive compulsive disorder, sleep difficulties, and drug and alcohol abuse. The short-term goal-oriented therapy focuses on changing dysfunctional images, beliefs, thoughts, and attitudes associated with problematic emotional and behavioural responses. Therapy will be tailored to Nadia's needs, and it will include cognitive restructuring, exposure therapy, and relaxed breathing. Nadia's mental health needs to be evaluated throughout the therapy process to determine its effectiveness. Self-report measures and discussions with Nadia will determine what is needed at each stage of the therapy process, including when Nadia is ready to terminate.
Thank you, Rebecca. I'll be assessing Nadia from a clinical neuropsychological perspective in the hope of shedding further light on her situation. As noted prior, the major concerns for Nadia are her behaviour at school and the possible relationship between this and her prior trauma. From a neuropsychological perspective, both her brain development and the presence of trauma are of importance. I will primarily focus on the trauma, but it is important to note that, as mentioned, being raised in a high-stress environment with little food or water, combined with traumatic events such as the death of her uncle, would have had measurable impact on the progression of her brain development. The trauma incident could be impacting her behaviour in multiple ways, depending on the site and severity of the trauma. Both of these factors can be illuminated further by psychological and neuroimaging tests. The type of unpredictable behaviour shown by Nadia can be considered typical for the presence of a brain injury. Brain injuries can cause sudden episodes of crying or laughing, and these emotional expressions or outbursts may not have any relationship to the way the person feels. Essentially, they may cry without feeling sad or laugh without feeling happy, and it isn't uncommon for an emotional expression to not match the situation the person is in, which again is evident in Nadia's case. Following an incident that involves brain trauma, like the one Nadia was involved in, a decline in memory and attentional abilities of the person are the most common forms of dysfunction. While memory and attentional tasks are supported by other networks in the brain, it appears that they have the most reliance on a cohesive communication between the neural pathways, as they tend to be impacted first. As is clear by her behaviour, Nadia is suffering from attentional deficits and may also be impacted by memory issues. Naturally, these questions can be answered through neurological testing. Narrowing down the region of the brain is an important step to determine what might be the scope of Nadia's dysfunction. Typically, patients suffering traumatic brain injury to the frontal lobe show decreased ability to govern or self-control of mood, have difficulties with their behaviour, and show trouble with their memory and coordinated movements. The Queensland Mental Health Service summarises damage to the frontal lobe as being hallmarked by a decrease in the ability to organise information and ideas. This can also be paired with unpredictable behaviour, which is essentially down to a reduced ability for planning. This is further exacerbated as sufferers often will be quick to frustration when these things aren't working out for them. Benelli and Cummings also found that patients with frontal lobe damage experience impaired executive functioning and impulsivity. These are typical of Nadia's situation and would make school and the schooling environment quite difficult for her to succeed in. In order to further clarify the region of the brain impacted by the trauma, the two inventories I will be recommending are the Frontal Systems Behaviour Scale, or the FRISBE, and the Iowa Rating Scales of Personality Change. Both of these have demonstrated efficacy in determining the region of the brain responsible for disturbances in behaviour. Firstly, the IRSPC is a more general test and was developed to detect several issues with brain behaviour, and thus is a good place to start. It also has demonstrated efficacy with detecting frontal lobe problems. This will be followed by the FRISBE, which provides a brief, reliable, and valid measure of systems and competencies of the frontal lobe. The FRISBE includes a total score as well as scores on 3 subscales. It is a 46-item rating scale and is far less time-consuming than an average neurological examination. The scale also offers ratings for both patients and teachers. After completing both the FRISBE and the IRSPC inventories, if it does not in fact appear that there is possible trauma, it is appropriate to refer Nadia on for a brain scan to further clarify the extent of the injury she has sustained. There is a choice between several options for scans. Some authors suggest that either a CT or an MRI are good options at this point. However, in this case, given that, as mentioned, it is quite likely there is a possible presence of PTSD, I'll be recommending the SPECT scan. The SPECT scan offers an accurate picture of the frontal lobe region we're interested in, without being impeded by possible calcium deposits, like the CT scan can be. But more importantly, it has been demonstrated to illustrate the difference between PTSD and the erratic behaviour that can arise from brain trauma by contrasting the two different brain regions against each other. If the SPECT scan does in fact demonstrate the presence of frontal lobe damage impacting behaviour, and also suggests that this is a more accurate explanation of behaviour outside of a diagnosis of PTSD, then I will be recommending a further referral onto a psychiatrist. This is an important step in Nadia's recovery, as the psychiatrist has the ability to determine whether or not drug therapy would be a good course of action for Nadia. If there is frontal lobe damage, the prescription of dopamine therapy may be a line of treatment for the psychiatrist, given it's demonstrated to be effective against trauma that arises specifically from frontal lobe damage. This drug therapy, combined with the suggestions from both Rebecca and Stephanie, ideally culminate in the best treatment outcomes for Nadia.